I'd like to thank Maureen and Viv for the invitation to speak on this topic, and Anthony for being my debate partner. I place a lot of LAMS as well as pigtail stents, so it was interesting to think through this, and I look forward to sharing my thoughts with you. I'd like to start with some points for your consideration. In the context of healthcare, a procedure or device may be considered superior to another if it has a better safety and efficacy profile, and if it's broadly applicable to the condition that is meant to treat, not just a subset of patients. Additionally, it should be reasonably cost effective. For the purposes of this debate, I'd like you to consider a few points. First, the quality of evidence regarding safety and efficacy data for LAMS and double pigtail stents. Additionally, I'd like you to think, how often do you require a pigtail after you've started a procedure with a LAMS? And how often do you require a LAMS after you've intended to start a procedure using a double pigtail stent? And finally, the last question I'll ask you is, if you could have just one stent hanging on your wall in inventory, what would that stent be? To thoroughly compare these two stents, we'll look at differences in technique, the clinical scenarios the stents are used in and their limitations, and the clinical outcomes. Double pigtail stents have been used in the drainage of pancreatic fluid collection since the 1990s, when it was typical to access the collection with a needle knife, place a wire, dilate the tract with a balloon, and then place the pigtail stents over that wire. And then in 2003, endoscopic necrosectomy was developed. This video demonstrates the traditional necrosectomy technique. We're doing this under EUS and fluoroscopy, CO2 and anesthesia. First, we take a 19 gauge needle and aspirate contents to see what's in there and send that for culture. We'll then inject fluid as a dilute contrast to stretch out the capsule and really thin it out so we can penetrate it with a stiff balloon over a wire. We'll then upsize that balloon to create a larger defect so that we can then subsequently access that with an endoscope. We'll keep the head of the bed up or the floor table up to prevent aspiration here. Again, it's under anesthesia as well. The patients are intubated. We'll then introduce the scope and see what we have to deal with here. Now, we can, of course, perform debridement, and there's no great tools for this necessarily. Here we're using a Rothman. You can use a snare or rat tooth forceps. The goal is really to fragment this and clean it up a bit. No consensus on how much of this to do. Lavaging is incredibly important. You can do this with a bacitracin solution or hydrogen peroxide or water. And then finally, we place pigtail stents at the end of the procedure. Alternatively, this is the technique that is typically employed when using an electrocautery-enhanced lumen-opposing metal stent. You access the cavity with your delivery system, open the distal flange, pull back, open the proximal flange, and you're done. We will now focus more deeply on differences in these techniques. With LAMS, there's no aspiration of fluid, which has several limitations. You don't know the content of the collection. Is there blood? Is there mucin? Is it a pseudoaneurysm or a cystic neoplasm? This may dissuade you from doing the procedure. Additionally, you don't send the fluid for culture, so you have less information on organism sensitivity, and you can't tailor antibiotics as well, and you don't know if there's a fungal superinfection. With LAMS, there's also typically no injection of dilute contrast, which may also be a limitation, as you can't see the full extent of the collection, and you don't know if there's fistulization of the colon or perhaps a pancreatic duct disruption. Another limitation of lumen-opposing metal stents is that they're not FDA approved for collections with greater than 30% necrosis. This is for a variety of reasons, including there's concern that the distal flange may not open up appropriately in dense necrosis, and that dense necrosis may lead to early stent occlusion with infection and the need for an urgent repeat procedure. It can also be challenging to perform debridement through a LAMS due to concern for stent dislodgement, particularly with scope angulation, tip deflection, and when trying to remove large amounts of necrosis. There's also legitimate concern that LAMS may not allow proper drainage of all aspects of a collection, particularly deeper recesses, and that as healing occurs, you could have islands of necrosis that are removed from the lumen. Another point that can't be emphasized enough is the limited stent dwell time with LAMS. With time, the distal end of the stent rubs in the extramural tissue and can lead to pseudoaneurysm formation and substantial risk of delayed hemorrhage. So these stents should be removed typically within 3 weeks. And for our last 2 points, LAMS are typically not good for small collections due to the size of that internal flange, and they are expensive, where you can get double pigtails for as low as $150 LAMS typically run over $5,000 a stent. Moving on to clinical data, here we have our first multi-center retrospective study looking at pigtails. There's over 100 patients, and they had a 91% success rate with a complication rate of 14% and 5 deaths. So good efficacy, but something to work on there was safety. The major limitation to that study was the variety of techniques employed, including freehand needle knife. So we performed a prospective series, or SCAMP, using a well-defined uniform technique, including EUS access, fragmentation, and lavage instead of aggressive debridement, and we took all patients off PPIs. We had similar success rates to that prior study at 86.7%, but our SAEs were considerably lower at 3.3% and with no mortality. And finally, we do have an RCT for this technique. This was performed in Europe with 22 subjects being randomized to surgery or endoscopy, and they used a composite clinical endpoint looking at major complications, new onset organ failure, new onset diabetes, and death. And you can see here where endoscopy really beat the surgical approach all across the board. There are many other studies where pigtails have been used. However, for LAMS, there's rather limited data. Several small series and some larger systematic reviews relying on those series with very low quality of evidence by the grade methodology. There is a randomized controlled trial comparing LAMS to plastic stents. 60 patients were randomized 1-to-1 to either go to LAMS or the plastic stent approach. This table shows the results. Resolution of SIRS and collection resolution are very similar. However, there's a trend towards increased complications in the LAMS group at just over 40% versus 20%. And of course, LAMS are considerably more expensive. Summarizing the limitations of these two approaches, with the traditional technique, more steps and more time are required, and there may be increased risk of bleeding on access. However, there's far more limitations with the LAMS approach, including less information regarding content of the collection, no information regarding fistulization. The distal flange may not open well in dense necrosis, and you may have early stent occlusion there. It can limit debridement. You can't necessarily drain deep pockets of necrosis. There's an increased risk of delayed bleeding with these stents, and it also may not be feasible to use these in small collections. So how often do you require a pigtail after you start with a LAMS? Well, certainly if there's greater than 30% necrosis, or if there are deeper recesses in that collection, you may want to put a pigtail through the LAMS. Additionally, once you remove a LAMS at 3 weeks, if there's a residual collection, you'll need a pigtail. And for small collections and pseudocysts, pigtails may be better as well. And how often do you require a LAMS after you start with a pigtail? Or when can you use a LAMS when you just can't use a pigtail? I thought so. So, final tally, broad applicability. Pigtails really win over LAMS. You can just use them in more scenarios. Outcomes data, well, certainly there's more outcomes data supporting the use of pigtails in wall-off necrosis compared to LAMS, and the comparative study really didn't say LAMS was any better, so pigtails win there. And then for cost, pigtails are certainly less expensive. So if you could have just one stent on the shelf in inventory for the treatment of pancreatic fluid collections, which one would it be? And I think pigtails win hands down. Thank you for your attention.